start, the field of neuroendocrine tumors really started 111 years ago when Obendorfer coined the term carcinoid. What he saw is that he's a pathologist who saw a group of tumors he felt like was cancer-like because they were very slow growing. So for the next 100 years, this area of oncology has been characterized by thinking about the disease as a very rare entity, a very boutique disease. In fact, as we've already heard, for a long time there wasn't much research in this area because it was thought really nothing really worked, and also it was relatively slow growing. There was a misunderstanding about how malignant or benign these tumors are. Then came, I think, many of the patient advocacy groups, and they recognized, these are zebras, but we need to think about the zebras and make sure we make the diagnosis. But I think the field has actually moved beyond that. I think we now understand these are not nearly as rare as folks think. These tumors are actually more common than people think. This is an update of our work that we, from our initial publication we published back in 2008, just essentially updating the epidemiology in neuroendocrine tumors. The red line represents the number of essentially cases per 100,000 population that are diagnosed each year. As you can see, over the past 3-4 decades, the diagnosed incidence of neuroendocrine tumor continues to increase. In fact, if you were back in if you go back to the 1970s, this was about a 1 per 100,000 per year in terms of recognized and diagnosed cases. It's risen almost 7-fold in that period of time to nearly 7 per 100,000. So, is it really possible that is there something environmental, is something new, or something going on that caused these neuroendocrine tumor to be increasing in terms of diagnosis and incidence this much over the period of time? We actually don't think it's actually necessarily any change in environment. We think it's always been there. It's just that they were poorly recognized. They were undiagnosed or not correctly classified. Because if you look for neuroendocrine tumors in a large series, so these are a couple of autopsy series from essentially one was done in Mayo Clinic in Rochester, one was done in Europe, and one was done in Hong Kong. And these are patients, who essentially die from unrelated reasons, car accidents, old age. And if you look for neuroendocrine tumors in these patients who didn't have any manifestations of neuroendocrine tumor, you will find them, roughly in 1 in 100 cases. And for small bowel, and 1 in 1,000 cases for the pancreatic neuroendocrine tumor. So I think the incidence of these tumors has always been actually fairly high, but we're recognizing them better. And also the question to ask then also changes. It's not what's causing the neuroendocrine tumor, but what causes the small benign neuroendocrine tumor turn into malignant tumors that causes the most amount of problem. So if you look at prevalence, so that's another way of looking at it, which is not so much number of cases are diagnosed each year, but number of patients who are essentially dealing with the cancer diagnosis each year, people who are alive with diagnosis of cancer each year, the number are much higher. It was even back in 2004 when we looked, it was over 100,000, and with the increase in incidence and also the improvement in outcomes, so patients are living longer. The last time we looked, again, it's over 170,000. So, if you look at this, the U.S. government official definition of a rare disease is a prevalence count of 200,000. If this trend continues, I think it will be pretty clear next time we update the data. We can maybe no longer classify this even as a rare cancer. So certainly, there's going to be less common rare subsets, but the entity as a whole is not nearly as rare as people think. But the neuroendocrine tumor is also not a homogeneous entity. It's composed of a number of different subgroups, and they have very different outcomes. This is a little bit of eye chart, so it's not really meant for trying to read too much into this. And we also have a little bit more updated data. We will show it a little bit later. But essentially, what I'm going to just stress is that if you look at the outcome of patients, say, with a appendiceal carcinoma tumor or rectal carcinoma tumor, and they're localized and not spread, the outcome is actually very, very good. Vast majority of patients with appendiceal and rectal carcinoma tumor that has not spread, that are small, less than a centimeter, are cured. In fact, many will argue that very little follow-up is necessary, because when people did long case series, they showed these tumors don't come back. Whereas the outcome for small bowel carcinoma tumor, even when it's localized, shows a high rate of recurrence. But if you look at the distant metastatic neuroendocrine tumor, so the patient who are diagnosed with neuroendocrine tumor who has already spread, the outcome is exactly reverse. Those people with small bowel neuroendocrine tumor tends to have a much better outcome, because the tumor, although has likely to come back or spread, but they tend to grow very, very slowly. There are other groups of neuroendocrine tumors from other sites tends to have a little bit more aggressive course. One of the questions that has always been out there, and we really didn't have a great answer for, is how likely is the neuroendocrine tumor that has been surgically resected, completely resected, how likely are they to come back? We had survival data before, but we were really never able to say, how often someone who had a tumor completely resected is going to come back. That's because these data are very difficult to come by. Large registry only can really have survival data. They really don't have, recurrence data. So one of the projects we did was to look at the SEER Medicare database. So this data is a little bit skewed. It's applying mostly to the older population, because that's where the data, that's where we have the data. But, we're beginning to understand by primary site, these tumors behave very differently. The couple of key drivers is the tumor grade. Those people who have poorly differentiated tumor, even when complete resection is possible, there's a high rate of relapse. Another key driver of this is actually primary site. And this is beginning to answer a question. Someone who has surgical resection, completely resected neuroendocrine tumor, how long do we have to follow the patient? What we see is that you see this big cluster over here, and then the outlier is this curve over here. So for most neuroendocrine tumors, 5-6 years out, if the tumor hasn't come back, the likelihood of the tumor coming back, when you follow them for another 5-6 years, is fairly low, because these curves representing percentage of patients who are essentially free from relapse are not really moving. They're staying flat. Whereas with some groups like pancreatic neuroendocrine tumor, although relapse can happen very, very late, we may have to follow a patient for a much longer period of time. Even if there's no relapse at 5 years, it can still happen potentially a little bit later. So, I think many patients with neuroendocrine tumors tends to obviously, read about the disease on the internet, and depending on which webpage you tend to read and which blog you read, people are focused on different things. The thing I want to stress here is there's, what drives outcome in terms of, the tumor, whether it's going to behave well, will be more aggressive. There's no single parameter that's going to tell you that answer. It's really a number of different things that affects how the tumor is going to behave. For certain, when the key criteria is stage, is the cancer localized to a single area? Is the cancer, has already spread to the regional lymph nodes, showing that it has that potential to spread? Or is the cancer, in other organs? So that's stage. Pathology has been an incredibly confusing area in neuroendocrine tumors, partially because the pathologists keep changing the definition. So that requires a little bit of clarification. Nowadays, we really look at two things: differentiation and grade. And differentiation really talks about how the tumor appears relative to a normal appearance of those cells of origin. And usually here we're talking about well-differentiated and poorly differentiated. Well-differentiated tends to have a much slower course. They tend to grow slowly. And the poorly differentiated is a completely different disease. They really have nothing to do with the well-differentiated neuroendocrine tumors. The behavior of a well and poorly differentiated neuroendocrine tumor is night and day. You might as well be talking about two completely separate and different diseases. Their management, their approach, and type of treatment applied is completely different. Then you have grade. Grade really talks about how quickly the cancer cells are dividing. Whether you look at mitotic rate with Ki67, they're highly correlated with each other. Right? There are just different ways to tell you how quickly the cells are dividing. Grade 1 and 2 tumors pretty much behave similarly. They tend to be slower growing. The grade 2 tends to be potentially a little bit more aggressive sometimes, and grade 1 tends to be a little bit slower dividing. Then there's this area called grade 3 neuroendocrine tumors. And with grade 3 neuroendocrine tumors, the differentiation is critical to understand. There's this group that are well-differentiated grade 3 neuroendocrine tumors. They're a little bit more aggressive than grade 2, but they're not quite the same as a poorly differentiated grade 3 neuroendocrine tumor, which we tend to treat a little bit differently. Primary site is also critically important. If you look at the genetic level and look at the chromosomal level, again, these neuroendocrine tumors have different primary site, may have different mutations that are present, may have different treatment strategies. Cancer volume, amount of disease that's present, whether there's one tiny little spot in the liver that even if it doubles in size, it may not cause any noticeable symptoms or risk, or there's a lot of tumor where we really need to get it under control. It's another important one. Functional and non-functional neuroendocrine tumor, this is talking about whether or not these tumors are causing hormonal syndromes, whether it's flushing and diarrhea or a tumor that's completely silent. And the way I view this is that if you have a functional tumors, there's two parallel process or things you need to manage. If it's a non-functional tumor, then you're dealing with really the oncologic aspect. Finally, the other part that's critically important is really the patient. We sometimes talk about performance status. If you've been in my clinic, Dr. Halpern's clinic, you'll get questions sometimes like, how are you doing? How active are you? Are you physically strong? Doing everything you want to do? Jogging and doing those things? Or are you more fatigued, tired, having a hard time, with activity of daily living? Because those things makes a huge difference in patients' outcome. In some ways, as important, if not more important than the patient's, than the tumor grade and so forth. General health, nutritional status, organ functions. So those are also very important. The site of primary tumors, is also an area that we need to talk about a little bit, because we just actually had a drug that was approved, a treatment that's approved for that the approval language talks about foregut, midgut, and hindgut. So what are we really talking about there? So this is really going back to embryology. In an embryo, there's essentially the way that that grows. There's foregut that differentiate into different organs, and there's midgut and hindgut. And in the lung is technically part of the foregut, but it's a little bit different. But essentially, when we're talking about foregut neuroendocrine tumor, mostly we're talking about neuroendocrine tumor arising from the stomach and in the first couple of portions of the duodenum. Midgut is really neuroendocrine tumors arising from the small intestine and maybe proximal colon. And hindgut is neuroendocrine tumors essentially arising from the rectum. And depends on which part of the world you're from, the type of neuroendocrine tumor you get is actually a little bit different. In Europe and Western population, you tend to see a little bit more midgut neuroendocrine tumor. You go to Asia, you hardly ever see a midgut neuroendocrine tumor, much like they see hindgut neuroendocrine tumors and so forth. So a couple of slides just on the progress that the field is making in terms of understanding how these tumors tick. There's a couple of ways of looking at how these tumors are acting. One is certainly to look at the genetics, and there's been a lot of resources pouring into understand the genomics of neuroendocrine tumor. This is one of the key papers that was published last couple of years by our European colleagues on essentially pancreatic neuroendocrine tumor, where they look at essentially what genes are mutated and how they are grouped together. They're essentially grouping these into 3-4 different groups. Technically 4 groups, but one of the groups is extremely rare. So there aren't that many of them out there. But what's clear is that there are certain key pathways that are involved. Menin, DAX, ATRX you heard about. They're all involved in telomeres. And these are essentially caps on the end of chromosomes, and it has to do with the cell division and so forth. And then there's an mTOR pathway which led us to look at drugs such as everolimus in neuroendocrine tumors. But generally speaking, the rate of somatic mutations or mutations on a specific gene in neuroendocrine tumor compared to other cancers is actually extremely low. And that's probably partially the reason why patients with neuroendocrine tumor have better outcome compared to many other tumors. But what we're discovering is essentially, although the rate of this, a distinct mutation, in terms of a base level is fairly low, alteration on chromosomal level is actually very high in neuroendocrine tumors. So many of you know that the genomes are packaged into this thing called chromosomes, and we have pairs of chromosomes, and there's 22 pairs plus the sex chromosomes, X and Y. This is a look at pancreatic neuroendocrine tumors. And we're seeing that there's 3 different groups. There's a group that the chromosomes looks pretty normal. There really aren't any additions or deletions. There's another group where literally, on 11 out of 22 chromosomes, normally we have 2 of them, and we have a pair. They lose one of those pairs. Another group where they lose 1 copy of the 11 chromosomes and simultaneously gets an extra copy of the remaining chromosomes. So it's a really fascinating picture. So what's really going on here? What's going on here is that you start with 22 pairs of excluding this X and Y sex chromosome. You start with 22 pairs. For whatever reason, probably related to mutations, because these patterns of chromosomal abnormality are directly also linked to MEN1, DAX, ATRX status, that you lose 1 copy on half those chromosomes. And it's always these particular chromosomes. It's not one patient loses chromosome 3, another loses chromosome 4. The loss is always on chromosome 3, chromosome 11, and so forth. This probably generates stress for the tumor because they don't have enough genetic material. So they start duplicating. They duplicate essentially an extra copy of all the chromosomes. So where there was no loss, now you end up with 3 copies of the chromosome. Where there's loss, you end up with back to a pair of 2, although it's not quite the same because normally the 2 chromosomes in that pair are different because you get some content from your mom and you get some content from your father, but because this is a copying of the remaining chromosome, they are identical now instead of being different. So these are some examples of what we're learning about the genomics of neuroendocrine tumors. The key takeaway here is that genomically they have relatively few mutations, but these tumors are characterized by more large-scale chromosomal abnormalities. Especially for I think some of our newer attendees, I want to just say a few words about diagnosis and workup of neuroendocrine tumors. So we talked about neuroendocrine tumors existing in different stage. So here's an example of a CT scan of a small localized neuroendocrine tumor in the small bowel. They can be absolutely tiny, a few millimeters in size. An example of a regional, when we talk about regional disease, so in addition to the primary tumor in the small intestine, it's kind of in the lymph nodes near where the primary tumor is. And the distant neuroendocrine tumor is one where it's kind of, you can see that it started in the small bowel. It's kind of tracking up the lymph node and it's kind of spread into the liver. So that's what we're talking about in terms of stage. So we often do imaging to determine the stage, whether a tumor is localized in one place, hasn't spread, we take it out, hopefully we're cured, or we need a little bit more extensive surgery because there are a lot of regional lymph node involvement. We need to be concerned about, essentially how much bowel we take out and so forth. Or it's a situation where, the tumor is kind of already out of the box. It's in many different places where we need to really work on systemic treatment. This is just another way of imaging these tumors with MRI, where you can see very small tumors. I show this is because we do have some patients who, for one reason or another, whether it's allergy or kidney function, cannot get contrast. In people who cannot get contrast, MRI can be often very useful because this is a scan that's done without contrast, and in T2-weighted imaging, you can still see them. Nuclear medicine, nuclear scans also have a role. This is an arterial scan. We do this for a couple of reasons. One is to understand the extent of disease. Another is to see whether these tumors have somatostatin receptor present on them. That can help us think about what type of treatment to apply, whether we start arterial type or real type, or eventually whether we do things like PRRT and so forth. A newer type of nuclear scan that we're doing a little bit more is the NET spot with gallium-68 dotatate PET. This is a much more sensitive nuclear scan. It's a little bit more convenient because it's done in 1 day rather than 2 compared to the arterial scan. You're able to see much smaller tumors. For example, this is a patient that we saw recently. Other than primary tumor, we would have never noticed this lymph node before because it's so small. And it looks completely normal, but it's lighting on the scan, showing us there's disease, outside the area that we know about. Another example, a tiny little bone metastasis. We would have never seen this by any other scans before. So these scans, sometimes, especially if you never had one, you get one, you may get a little confused because now it's showing a lot more disease than before. It's just because these scans are a lot more sensitive. I would say that they're very useful for us. And especially in the, when you're trying to make a major decision about whether you're going to have surgery or not. But sometimes arterial scan, if you just want to know whether receptors are present or not, the arterial scan can give us adequate information as well. I mentioned this is that this is still an area that sometimes we have challenges with insurance companies. There's a couple of insurance companies we know that don't even ask, because every time we ask and push them, it's always no, and that's an area that that's a little bit of a challenge. Okay, next thing you hear a lot about out there is blood tumor markers like hormone-producing A. These are secretory granules elevating urine endocrine tumors. Things to keep in mind is they can be elevated in normal patients without cancer. If Dr. Halpern and I go out and take some proton pump inhibitors because we have, if we have acid reflux or something, I can guarantee you when we check, it's going to be elevated. So mild elevations in hormone-producing A are very non-specific. And this is a marker you also have to, even if you are considering and watching it over time, you almost have to watch it on a logarithmic curve, meaning a small increase in hormone-producing A is really not meaningful at all. It's a doubling or quadrupling of hormone-producing A that's giving you information. Just also, remember there are a number of other things like chronic gastritis, kidney and liver function, inflammatory bowel disease that can cause falsely elevated hormone-producing A. Another one that's frequently done is 5-HIA. This is a marker of serotonin metabolism. Just remember there are certain food products you need to avoid when doing this test for about 3 days, because there are certain nuts that are very high in serotonin. If eating nuts and these things and do a 5-HIA, it's going to become elevated and harder to understand. And there are certain medications you should also kind of avoid. Guafenicin is a very common in over-the-counter like cough medicines for cold and flu, but they may affect a patient's 5-HIA levels. You can do this in urine, in blood, or you can do something even like serotonin. One of the reasons often we do the 24-hour urine collection is that this is a neurotransmitter, so it's going up and down all day depending on your stress level. When you do one of the reasons you do a 24-hour collection is that it gives you a 24-hour average of what's going on over time. Other markers in very specific rare types of neuroendocrine tumors are shown here. I won't go too much into it. The principle of marker assessment is there are lots of markers out there. The expression can change over time. We do large panels of markers at key points, like a diagnosis relapse, but you don't need to do every one every time. It doesn't give you any additional information. Briefly about therapy, there are other talks on therapy later, so I won't spend too much time on here. When we talk about therapy, we're really talking two things: hormonal syndrome and tumor control. Carcinoid syndrome, flushing, diarrhea, carcinoid heart disease. And just remember there are specific triggers like emotional stress, food, alcohol, diarrhea, certain type of food, and so forth. These things do affect quality of life. This is some work we did years back where we surveyed patients actually through the internet on how many bowel movements and how many flushing episodes they were having, and doing a quality of life questionnaire. Here, I think we're talking about RAND 36, but we did PROMIS 29 as well. What we're beginning to see is that the quality of life really starts getting affected when people start having more than 4, 6, or 7 BMs per day. The quality of life is relatively maintained when the number of BMs is seen 0 to 3 type of period. Same thing on flushing. What we learned here is flushing actually corresponds even more tightly with quality of life. Even 1 to 3 flushing episodes in a 2-week span of time tend to be correlated with a decrease in quality of life. Although we talk about diarrhea a lot more, sometimes because when you think about the flushing, it can be also very important in terms of quality of life. Treatment is somatostatin analogs, whether it's octreotide or lanreotide. They bind to receptors on these cells and essentially stop the secretion of the hormones. There's just a few words on refractory carcinoid syndrome. Sometimes we have a hard time controlling carcinoid syndrome, and we need to remember carcinoid syndrome, or hormone, is only one cause of diarrhea. In patients with carcinoid tumor, there often can be many different causes of diarrhea. The hormone production is one. Steatorrhea is one. So some patients start on sandostatin or start on lanreotide, and diarrhea gets worse. And sometimes that's due to the side effect of the drug, because the drug slows the ability of your pancreas from making digestive enzymes. And so if you eat and you have diarrhea that's have some shows small absorption, sometimes we add things like enzymes to help with that. Another big one for small bowel carcinoma patients is short gut syndrome. The extensive resection sometimes can leave people with not enough intestine to absorb the food. Patient with uncontrolled syndrome for a long period of time, they can have pellagra, which is essentially deficiency in certain type of vitamin that can cause diarrhea. Brief summary. Before 2011, our ability to treat these tumors were quite limited. There was only a single drug FDA approved for therapy. It's only for pancreatic neuroendocrine tumors. But now we have a lot more options. Just yesterday, PRRT was approved. So PNET, we have everolimus, sunitinib, lanreotide, PRRT. GI neuroendocrine tumor, lanreotide, everolimus, and PRRT. For lung NET, it's still very limited option. There's only actually one drug approved, and that is everolimus at this time. There are other drugs that we know that has activity, but they're not necessarily FDA approved. We do use them. So I'm going to skip this slide. This is showing just where the data and which trial demonstrated activity in what setting. But generally speaking, we use somatostatin analog in the earlier part of the disease, and the targeted agents in patients with more aggressive tumors. This is how I think about management of neuroendocrine tumors. Primary site disease burden and aggressiveness determines how we treat them. There are situations I will leave patients actually completely untreated. This is the quote, watch and wait approach, and some people are not comfortable with that. But let me show you an example. This is a patient with a pancreatic neuroendocrine tumor with liver metastasis that we see here. Very little disease, no symptoms. The patient was young, very active. He was doing lots of stuff. So we had a long discussion, after which we decided, if this tumor grew by 20%, it's not going to cause any sort of danger. We can watch it a little bit and make the decision to really work on maintaining quality of life, right? So here's the same tumor 8 years later without any treatment whatsoever. Absolutely no change. If I had given this patient somatostatin analog for 8 years, we would have said that, oh, maybe the somatostatin analog stopped the cancer growth for 8 years. But in fact, this patient actually didn't need anything for 8 years. So is this a real tumor? Maybe the pictures are just off or something. Well, here's the arterial scan 8 years later. That's a real tumor there. The tumor is still there, but in this case, in 8 years, it showed absolutely no change. So when patients have very little disease and they have absolutely no symptoms, and shows incredibly indolent course, sometimes we concentrate on quality of life and save the interventions for later. So that sounds really complicated. How do you make the decisions? Here we use a multidisciplinary team. Here the center of the team here is often the medical oncologist, but sometimes if you have very localized disease, early stage of treatment, the surgeons are in charge, but we work together, and in difficult cases, we discuss the cases with our radiologists, nuclear medicine specialists in planning the best care. And not to forget dietitian, nursing, all these things are super important. So have we made any progress? We talked about a lot of this. Have we actually made any progress that impacts the patients? We have new treatments, lots of new drugs. Here's a look at survival of patients with neuroendocrine tumors over time. Back in 2000, 2004, compared to now, what these data is showing is that in patients with distant neuroendocrine tumors, the risk of dying from neuroendocrine tumor is decreasing. So these hazard ratios sometimes can be a little bit difficult to grasp in a meaningful way. So another way to look at it is median survival. When we looked in our last publication in 2004, median survival of patient with small bowel carcinoma tumor that has already spread was about 65 months. When we look now, more recently, it's 103 months. For pancreatic neuroendocrine tumor, the impact is even more. It was 27 months before with metastatic pancreatic neuroendocrine tumor. It's more than double to 60 months. And these are just medians. That means half the patient live short, potentially shorter than that. Half the patient live actually longer than that, maybe 200 months, maybe even more. And obviously, for us to have survival figures, patient how they're doing over 100 months, we're talking about patients that were treated, diagnosed a long time ago. We really think patients who are, being diagnosed and managed today actually probably will have even better outcome, because actually this is an area in oncology there's a lot of progress actually being made. Thank you.